I'm Dr. Theoharides. I'm a professor of pharmacology and internal medicine in Boston, the United States. I have been studying for many years patients who have multiple problems that unfortunately are not diagnosed by any physician, which creates serious problems in them and in the patient's families, since most of the time they think it's all in their heads. We will hear from two patients from different parts of the world telling their stories, how long it's taken them, how many physicians they've actually encountered before a diagnosis was made. And during this process, we will actually discuss possibilities of how to diagnose these diseases and give hope of treatment that may eventually help not only the patients, but their families as well.
Hi, I'm Lisa. I'm 45 years old. I'm from Copenhagen, Denmark, and I'm a documentary maker. I got ill 3.5 years ago, but looking back, I actually think I had issues my whole life, which I just dealt with and thought that was kind of normal because you only know your own body and your own life. But growing up, I had heavy, what we thought was allergy symptoms, and also a couple of anaphylactic shocks. Reacting heavily on grass was what we knew. And then I constantly had a sore throat. I'm kind of born with sore throat. But I lived with it and never saw it as a handicap, just part of life. And I lived a really, really active life until 3.5 years ago, where I went to the doctor actually with a running injury, but also mentioned to him that I had diarrhea issues for 1.5 years, and he said, well, you have to have that checked. And I did. I saw a doctor who put me on immune-lowering medicine, and I don't know whether that has been a trigger or not, but a couple of weeks later I got really ill with what I thought was a virus to begin with, and had multiple symptoms through my body, from my esophagus cramping. I couldn't eat. I lost 22 kilos in no time. My food wasn't digested at all. I constantly thought, well, on Monday they're going to find out what's wrong with me and I'll have a diagnosis and it will all be corrected. But I just saw more and more doctors and had more and more different diagnoses. Everything from having Crohn's disease to esophagus disease to heavy reflux disease. It was like I woke up from one day to another from being well, suddenly having 20 chronic diagnoses, which of course was really frustrating, but also kind of a mystery to me that could happen. But it was like nobody could detect this. I had brain fog. I still have extreme fatigue. I had blackouts. I have been lying for hours in and out of what feels like in and out of consciousness, just being awake, not being awake. I've had more anaphylactic shocks, taken to the ER typically after eating, looking like what could be an allergic reaction, but the doctors at the same time couldn't quite detect it. So I've been the mystery patient for 3.5 years, and been using a lot of effort to stay positive and to keep trying to look for a solution, because I believe that there could be a little more life quality in life than there is right now, still struggling with a lot of these symptoms.
So we had a chance to hear a bit about the medical history. Lisa, if I were to start with you, would you give me what might be the worst symptoms you're experiencing now?
What I call the more neurological symptoms, because I know it's popularly called brain fog, but where you kind of disappear. There's a wall between you and the world out there. I still have a lot of fatigue if I'm on production for a day, because I'm still trying to work all I can. I'm suffering 4 days after I'm having the bill. I still get blackouts. I have extremely irritating migraines. I get those attacks where I get kind of emotional, and I know now that perfume is one of those triggers where it's like I have an urge of crying, but I've got no idea why.
Right. And would you say that those actually occur more often at certain parts of the year, or are they there all the time?
This is really weird because I have grass allergy and I've had it my whole life. But I actually think that the humid periods, I live in Scandinavia, and I figured out for those 3.5 years, it's like a detective work, you know, you have to find out what do you trigger on and what don't you trigger on. There's no doubt that for me, the drier the climate, but not too warm though, but the drier the climate, the better. So it's really heavy for me to get through the winters and the falls.
Okay. Hi, my name is Julia. I'm 37 years old. I live in Michigan in the United States. I'm a registered nurse by trade. I have not worked in that field for a while due to health issues that gradually worsened over time. When I was a young child, going back as far as I can remember, I had a lot of gastrointestinal issues that I never spoke with anybody about, never spoke to my parents. I thought it was normal for me, thought it was kind of embarrassing, and just didn't really discuss it with anybody. As I got into my teen years, I started developing some other things, headaches regularly, a few spots on my skin that would welt and itch and hive. Again, I just thought this is my body and didn't really say much to anybody. I think I might have mentioned it to a doctor here and there, and they're like, I don't know. So as time went on, I developed other symptoms as well. I started having a lot of heart racing, a lot of fatigue, weakness, reactions to cold and heat, reactions to certain foods. Stress was something I picked up later that I realized was a major trigger for me. I have a lot of trouble with my memory, which we kind of call brain fog. I have trouble with my short-term and my long-term memory. Sometimes my mood is a little bit irritable out of the blue. I react to a lot of things in my environment, a lot of foods that I've had to change with my diet. And I've seen a number of doctors over the years, very difficult to find answers and find some way to bring all of this together, all of these different symptoms. Ultimately, I would say it was a few hints from a few doctors over the course of all of this, and then my putting it together and starting to do some research on my own. And I was able to finally start getting some answers and find the right doctors to help me with that.
How about Julia? What would you say are the worst symptoms?
Oh, I can relate so well to what she's talking about. I would say in addition to, well, what maybe falls under the brain fog and the cognitive and neurological issues, anxiety, severe anxiety that I'm fairly stable in comparison to the spring and the winter time. When the pollen or whatever is in the air is not there anymore, when it's not warm, I'm not reacting to the heat. I would just say as soon as I start to detect something in the air, it's anxiety, it's cognitive problems, it's forgetfulness, it's irritability, very, very difficult to deal with. And people around you don't necessarily understand what you're going through.
Would you say that that's true for you, Lisa, too, that people just couldn't understand it?
Not at all. And still is like that. And it's at one point I've given up trying to explain. Yeah, they get the short version, but it's been really, really hard to have the surroundings to understand what was going on, because I went from being a really active social person to a really non-active, non-social person, because I also reacted to everything. So I drew back.
It's true.
Not to be triggered and not to, there's been, I wouldn't say a lack of understanding, because I also understand that they don't understand, but it's just a mystery what happened to her.
So how many physicians would you say you visited over the last 10 years?
I've been ill for knowing I was ill for 3.5 years. And the first year was really intense, because I was really ill and I was in and out of ER, and they saw all this multiple symptoms in me. But in Denmark, I don't know how it is in the other parts of the world, but there's a ward for esophagus, there's a ward for the gastro, and they don't necessarily work together. And I just went from one ward to another ward to a third ward. Maybe I saw 60 doctors within the first 2 years.
Amazing.
And had more and more and more diagnoses, varying from Crohn's disease to one of the first doctors I saw. She was a gastro doctor. And for some reason, she couldn't detect anything in her tests. And she actually said to me, I think you've got Munchausen disease.
Oh my goodness.
And I was like, yeah, definitely, being 42 years old, never been ill before, jumping out of the closet as a Munchausen. But, you know, that's also been part of the tough journey. I think that, you know, that if they can't detect you right away in the medical system, then they're really fast with a diagnosis and then you're out of the door again.
How about you, Julia?
I think I had it pretty good in a way once I realized that my symptoms were progressing. It was over the course of a few years. I saw several doctors, but I think that I was onto my diagnosis just on my own research and little hints along the way from doctors, like a skin biopsy where the doctor was looking for urticaria pigmentosa. Once I had that information, which I tracked down later when the symptoms started getting worse, and I thought, is there a connection? Because the spots were getting to be more, it all came together. It all came together.
So we heard quite a bit of your medical histories. Lisa, could you tell me what would be the worst symptoms that you're experiencing now?
Yeah, but that's definitely what I call the more neurological symptoms, which is brain fog. Like there's a distance from me to the world and I can disappear totally in thoughts. I haven't got a very good memory anymore. I get heavy migraines. I get blackouts. I get extreme fatigue. I can pay for a hard working day for a long time after. I can pay for I still fly because I insist to move myself around in the world, but that can mean 5 days in bed with headaches and I call it the cycling helmet. It's like I'm wearing a cycling helmet which is 16 sizes too small because there's a lot of pressure here.
How about you, Julia?
Very, very similar. And in addition to the neurological issues, which I would say would be forgetfulness, forgetting things that I was thinking about 2 seconds ago, would also be extreme anxiety that comes on when I'm being triggered by something.
These are, by the way, symptoms that physicians most of the time do not understand because they do not relate to the other symptoms. They may have been gastrointestinal, skin, allergies, etc. So how difficult has it been to actually get any physician to listen to you? Either one of you.
Very difficult. Yeah, you kind of go through quite a few. And it's really about not necessarily finding a specialist. A lot of the time, it's just about finding a doctor who cares enough and is willing to stick by your side and work through it with you and has an open mind to maybe what some of the other specialists will say.
It's very important. How about you, Lisa?
Yeah, right. I think it's been extremely difficult and I haven't still been able to find, I come from a small country, but I haven't been able to find a doctor who can work with me here. Actually lost my two, I don't know what that's called, the house doctors you've got, who said the last one said, I can't work with you because I don't believe in these symptoms. And the first 1.5 years I was ill, I saw maybe 60 doctors diagnosing me with different diagnoses from Crohn's disease to Munchausen disease.
Yeah. By the way, that's a problem where we think that the patients themselves actually do harm to themselves and they sort of fabricate everything, which is the worst thing that anybody can tell a patient. So how isolated do you actually feel when you're dealing with so much on your own, basically? How difficult is it?
It's isolating in so many ways. It's emotionally isolating when people around you don't understand the condition, they don't understand what chemically it's doing to you, to your brain, to your mood, to your coping ability. They don't understand that you have triggers and that stress is one of them. And so you just don't always get the breaks that you really need from the people around you. It's very isolating. And it's also isolating in the sense that you may not be able to do the things that you could do before. You may not be able to participate in some of the activities you enjoyed, eat some of the foods that you enjoyed. You start feeling like a bit of an outsider or an outcast. And I think it's really hard when people don't acknowledge, ask you either how you're doing or, just acknowledge that what you're dealing with is real.
True. These are obviously, because of your work, you had tons of people that you knew. Are they all with you now?
No.
So
no, I think, but I think it's a mix of course, because Julia and I have a lot of similarities, but I think what is really different is the way how we got sick, because you were kind of growing and I was gone from one day to another. And I think it looks really mysterious to my surroundings. And I also think it gave them, I think it was, there was a lot of gossip. What is this? And they can't give her a diagnose, or is it mental? And I just actually experienced that a lot of people pulled themselves away from me because they were afraid to talk to me what this is about. And at the same time, I was so intolerant to a lot of things that the first half year I was sick, we lived in our car because I couldn't be in any environment inside, which also looked really weird to people.
Of course.
So I couldn't attend parties and be with people like I usually did. So in both ways, it's been really isolating, I think. And when you say lonely to people, it doesn't mean only physical loneliness. It also means loneliness in that you don't get the understanding with any doctors. They just say, what you're describing right now, that's not a disease. I don't recognize anything.
Absolutely. Well, let's see if we can sort of start pulling some facts together. Firstly, to give some credit to the medical profession, it is very confusing because many of the symptoms you both actually described could fall under potential different diagnoses. So there is a diagnosis for chronic fatigue syndrome, where people get debilitating fatigue for over 3 months. We still don't understand why. But many patients like yourselves would have fatigue. So someone could say, well, it could be chronic fatigue, even though we don't know what it is. Many patients have a lot of sort of diffuse muscle aches, and I think both of you actually do. So someone could say that's fibromyalgia, another disease that we still don't understand. And interestingly enough, both diseases, chronic fatigue syndrome and fibromyalgia, do occur as bona fide diagnoses in patients like yourselves, even though many of these symptoms might be coming from another cause that we will discuss shortly. Since many of you also have gastrointestinal problems, and since many of these symptoms worsen by stress, and we will talk about stress, and by stress, I definitely mean physical and emotional stress. It's not like everything is in your mind. Someone could say it could be irritable bowel syndrome, where you can have either constipation or diarrhea, a lot of cramping, for which, again, we don't have very many drugs. So you're still left, without anything. But there are some telltale signs, and both of you have mentioned different such signs that should have tipped, and in some cases, like Julia's case, did tip at least one colleague. In her case, she had some small sort of cafe au lait spots in her extremities. They are not really like moles, but they do actually itch when you scratch them. And in fact, in certain cases, such patients, if you actually just take your back of your nail and go like this, they will get a little welt. We call it dermatographia. Not everybody that has those symptoms will end up having the problem we will discuss, but these are telltale signs. Also, another telltale sign in hers was that during allergy season, a lot of the things she described would get worse. And you indicated earlier that mold seemed to actually do a job on you. So those symptoms should alert a physician to think about a particular cell type, which is called the Mast cell, M-A-S-T. Mast cells have been known for the longest time because they're involved in allergic reactions, typical allergic reactions. And they've been involved because in 1947 they were discovered to contain histamine, and histamine is one of the molecules that can cause such problems. And this is why we use antihistamines, medications that block the action of histamine after it has been released. However, over the years, and I dare say we were the first to actually show this, mast cells have been now definitively shown to release as many as 100 different molecules in addition to histamine, some of which we understand, such as the class of molecules called leukotrienes that are involved in asthma, or the class of molecules called prostaglandins that are involved in pain and inflammation, but many others that we don't understand. And to this day, we do not have a truly mast cell blocker or a truly anti-allergic drug. So, going back to your symptoms, one of the things one would do or should do is if there are such spots and a thought that these are really unusual, then we should biopsy them. And if you biopsy them, then you find out that there's a collection of these mast cells right in that small area, and that's a telltale sign that this is a disease that relates to mast cells. Unfortunately, you cannot biopsy the brain, and even though we biopsy the gut, most of the time, we don't know where to biopsy. And in Julia's case, her intestine was biopsied, and even though she has tons of gastrointestinal problems, they could not identify any increased number of mast cells. So when we're dealing with this disease, either we talk about number of mast cells, and or we talk about the mast cells being ready to fire and cause problems through many of these, we call them mediators, that are being released. So how do you actually chase them down now? If someone does have these skin problems, we call that cutaneous mastocytosis, or sometimes we call it urticaria pigmentosa because it's pigmented and it itches, which is what urticaria means. If patients have mild symptoms, and neither of you, in my mind, has had mild symptoms, they might not do anything else, and they might say, okay, take some antihistamine, maybe change your lifestyle a little bit, and things will get better. Well, almost 100% of the time, symptoms don't get better. And in fact, many of you are so sensitive that you cannot tolerate even the typical antihistamines that we would otherwise prescribe, at least for the mild symptoms. In fact, both of you were prescribed at some point steroids that we give for anaphylaxis, which is a severe allergy, and you both responded negatively to steroids. And that's a very important thing to remember because that's the first thing physicians will say, well, let's put you on steroids. If the symptoms are worse than what otherwise one would say, well, go around your life with a little antihistamine, then we might think about other things. So what would be worse? We usually think if there are more than one or two organs involved. But in your cases, you already had more than one or two organs involved, and someone should have actually jumped in and made the conclusion a little earlier. In Julia's case, it was a little earlier, you're still struggling, and we will talk about that. So what do you do then? It so happens that the mast cells that look like a soccer ball filled with about 500 ping pong balls, each ping pong ball having histamine and another 20 molecules, and during the reaction, not only those are being released, and we call that degranulation, but another 30 or so molecules are produced and usually are released 6 to 24 hours later rather than the immediate reaction that can take place within seconds. So can we measure any of those mediators, as we call them? A large proportion of the secretory granules that the mast cells contain is a molecule called tryptase. I call it a meat tenderizer because that's exactly what it is. It's a proteolytic enzyme. It is released all the time in patients like yourselves, and where there is a crisis of sorts or a trigger, it is released even more. So colleagues do measure tryptase in the blood, and if it is high, that's what we call a minor criterion for diagnosing what is now called mastocytosis, but I will define that a little later as well. If, however, the symptoms are severe enough, then we have to do a bone marrow biopsy, usually done at the pelvis, and there we're looking for how many mast cells, whether they cluster together rather than being spread out, and whether their shape, rather than being nice and round, is funny looking, many times spindle shaped. If you do have that, that's a major criterion. And then it so happens that over the last 10 years or so, it was discovered that a specific area on the mast cells, called receptor, that binds a growth factor that makes the mast cells grow, a stem cell factor. So the stem cell factor binds to a receptor that's called c-Kit. It turns out that c-Kit has a mutation and it self-activates itself. It does not need the stem cell factor anymore. So it makes the mast cells grow, and once they grow, they go all over the body, and you have many more mast cells in many parts of the body that they respond also much more easily to various triggers, even though we still don't understand why they respond to certain triggers, like, for instance, scents, perfume, etc. So if you have the mutation, if you have the cluster of the mast cells, then we're looking at any of the so-called minor criteria. So minor criteria would be having tryptase in the blood being elevated or having cutaneous mastocytosis. Then the diagnosis is systemic mastocytosis. And once you have that, if the symptoms are mild, then we call it indolent systemic mastocytosis, which is what Julia has. Or we call it aggressive if the symptoms are so bad that one would really have to take drastic measures to lower them. However, over the years, there have been numerous cases of patients who have all the signs and all the symptoms you're describing, but tryptase is normal, the bone marrow biopsy is normal, there's no mutation on the c-Kit receptor, and we just didn't know what to do. So with a lot of effort by a number of colleagues, and with a lot of effort from the Mastocytosis Society in the United States, first a video was produced about 5 years ago or so that was called Mast Cell Activation Symptomatology, not allergy, and that is given free to physicians and anybody else. And the idea was to sensitize everybody that if you do have activation of the mast cells, you can have an awful lot of different symptoms, and it does not have to be allergy by the book. And since then, an effort was made, and colleagues from the Brigham and Women's Hospital at Harvard and others and myself convinced the American Academy of Allergy, Asthma, and Immunology, and now there's a new diagnosis, which is called mast cell activation syndrome, which means that everything can be negative, but you have the symptoms, which is very important because, number one, the patients now have something to say, I have. It's about to be included in the whole roster of diseases by a number of insurance companies, so they will be covered. And it allows us to study them because at least you can bring them in and start saying, are these patients different than classic systemic mastocytosis? Now, there are a number of tests that are absolutely important in my mind to be done, but yet they're not part of the diagnosis, and they do not justify physicians sometimes to ask for them because they cannot be part of what we use for the diagnosis. And that is that I mentioned earlier prostaglandins are involved in pain and flushing, and of course histamine is. But prostaglandins and histamine are broken down in the blood within a minute. So if you were to measure it in the blood, you're never going to see them elevated. So we have to ask for collection of 24-hour urine so that if during that 24 hours there might have been an episode and they were broken down, at least we'll be able to measure the broken down products in the urine.
Can I say something?
Yes.
Yeah, because I think one of the big catch-22 in this situation is that a lot of the things that the medications I've got and the supplements I've got, I have such a hard time tolerating.
Correct.
And that's when you feel totally gone, because how do I get out of here then?
Correct. So in fact, it's a catch-22 because even if you were to tolerate certain antibiotics, the antibiotics destroy the flora in the gut, and then that might allow actually parasites and other bacteria to actually raise their ugly head and cause problems. And in fact, right now, we're writing a major review about what we call the microbiota, the gut, the brain, and allergic diseases. So hopefully we'll sort of bring all of this together. Maybe the next time we meet, we should talk about that at length. So going back to sort of symptoms in treatment, it is important to isolate symptoms to the extent possible and address those symptoms to the extent possible. So if someone had, for instance, asthma, or they have symptoms of shortness of breath, the mediators from the mast cells that are called leukotrienes are high on our list because they constrict the bronchi. And they are so high in our list also if the classic trigger of the mast cells, which is called immunoglobulin E or IgE, is high, because in those cases, we can either use a drug. There are many drugs, but one drug is called Singular. Some people tolerate it, some don't, that deals with the leukotrienes. And there's another drug that takes care of the high IgE, or at least patients that seem to respond mostly to allergens, called Xolair. One is a little easier to tolerate than the other, but I'm mentioning them because as we talk about the symptoms, and as we isolate symptoms, and as we isolate what might be causing the symptoms, there are drugs that we can use, and if we were to use them, within a few months we will know if they do make a difference or not, and then move on to something else. So the fact that we do not have a mast cell blocker should not necessarily keep us from thinking that there are ways to at least address different symptoms and potentially put medications together. Now, moving forward again, let's say we measured everything at 24-hour urine, everything was negative. And we measured tryptase and it was negative. And we measured the bone marrow and it was negative. So now you're in the worst predicament because everything is negative and no one is going to believe you other than the symptoms. Okay? Well, most of the time in medicine, if we can address the symptoms effectively, that's what we need. How often does this condition occur? We used to say that mastocytosis is a rare disease. It is a rare disease in the sense that it is rare to have the bone marrow findings and the mutation on the c-KIT receptor, as Julia has. However, when we start dealing with all the patients that now qualify as mast cell activation syndrome, we might be talking 1 in 150 people or so, which is an enormous amount. And then within that, you might be able to have individuals like the diagnosis they gave you of multiple chemical sensitivity syndrome, which we still don't understand. And I have patients that get itchy and they get almost paranoid after working on a computer for X period of time. And a long time ago, we used to have actually screens that will ground electromagnetic radiation, and then we forgot all about them.
And today you can't say it loud because there's no, and I'll say it loud today, there's no doubt that I react on electricity and on cell phones, but you can't say it to doctors because, or to the world because they think you're crazy.
That is absolutely correct. However, coming back to the diagnosis, there's no question, therefore, there are certain tests that we can do in 24-hour urine, and there are certain tests that we should do in the blood, especially when people flush, those people who flush, or have very strange-looking, blotchy kind of red appearance of their skin every now and then, like you, Lisa, told me you do, because that indicates what we call edema, or sometimes it's called angioedema, which is basically the same thing. Angio means the blood vessels, and edema means that fluid comes out of the blood vessels. And there are certain types of angioedema, and sometimes if we don't understand it, but we know that it occurs after stress, for instance, we call it angioneurotic edema. Be it as it may, there are certain tests in the blood, they're not expensive, such as what we call complement fragment 3A and 5A, something called cryoglobulins, something called, it's a breakdown product of the platelets when they actually clot, that can be measured, and all of those can be telltale signs. There's also a molecule that is definitely involved in at least this kind of symptoms that's called platelet activating factor, or PAF. We didn't know exactly what it does, but there's a symposium actually today, a couple of hours, at the Congress of the European Academy of Allergy and Immunology here in Copenhagen, where they will be talking about this drug that I mentioned earlier, rupatadine, which is not only anti-eosinophilic, antihistaminic, and a mild muscle blocker, but it also blocks PAF. Except that PAF is very difficult to measure right now, so it might be a few years before this becomes routine. And if one were to ask for some of the others that I mentioned, such as the complement fragment 3 or the clotting part, which is called D-dimer, some of my colleagues might think, I'm crazy for even asking them, because they don't enter into what we call the differential diagnosis right now. So either they will just discount everything, or they'll lump everything into something, and they will be missing kind of all of those. For instance, if prostaglandins are high, and if you're not sensitive to aspirin or aspirin-like drugs, such as the ones we have in the United States, they're different names, ibuprofen, for instance, then you might be able to take ibuprofen, and some of those symptoms might become fewer, and Julia, for instance, is on ibuprofen. To the extent that there might be a lot of, especially stomach-related problems, and you mentioned earlier that you had difficulty in cramps on your esophagus, it could be that it is what we call eosinophilic esophagitis, in which case something like rupatadine or the other drug ketotifen would be very helpful. But you might not be able to take aspirin-like drugs because of that. It's very important to also take the so-called type 2 antihistamines, or histamine receptor 2 antagonist. Those would be, for instance, cimetidine, ranitidine, by the name MPhil, because mast cells are involved in making the so-called parietal cells of our stomach release gastric acid, and that obviously will cause gastritis and it might cause reflux. And there are also studies showing that giving the two together, a type 1 blocker and type 2 blocker, relieves the symptoms elsewhere in the body as well, for reasons that we don't understand. However, what we have to keep in mind, which is against medical dogma, is that many patients get used to this medication, so you have to increase it over time. So Julia has increased, for instance, pretty much every medication she's taken over time. And if someone were to ask, well, how much, let's say, Zantac you're taking, it might be 150 milligrams 6 times a day, and someone will say, my God, that's way too much. But for the individual patients, if it works, it works. So the only thing we should worry about is potential side effects, which sometimes can happen. For instance, one of the earlier meetings of the Mastocytosis Society, where I was invited to lecture, I had the chance to talk with one of the founders of the society, and we were talking about the side effects, and she had told me she found it very difficult to urinate. Well, it so happens that all the antihistamines have action that we call anticholinergic, and anticholinergic action will put you in retention. So the benefit of the antihistamine may have been fine for itching, for the blood pressure or whatever, but obviously she ended up having a problem elsewhere. But because it varies so much from person to person, and because we wanted to make the story a little more palatable, if you wish, to physicians as well as to patients, we wrote a review recently, and Julia was kind enough to participate, not only because she worked on the paper, but because we used some of the bone marrow findings from hers with your permission. But we basically called it a spectrum of mast cell activation disorders. We didn't call it mastocytosis, because mastocytosis is way too restrictive right now. And mastocytosis is primarily seen by hematologists, and hematologists are few and far in between. So by calling it a spectrum, more patients, I think, would feel that, yes, I can belong there. By calling it mast cell activation disorder, clearly we're talking about the activation of the mast cells and not necessarily the number of mast cells, which is also most important. Now, most everybody asks at one point or another, is there something natural that can help us? And I already mentioned that some of the supplements that we use and help develop have natural molecules. The one that I particularly like is called luteolin, and it's purified from the tea chamomile. And in order to increase the absorption, we mix it up with olive seed oil. So I usually joke, even if it doesn't work, you get a little Mediterranean diet in a capsule. But we made an effort, and there will be another review. So here is a review we wrote recently, again, within this year, talking about dietary interventions for atopic diseases. Now, that's another jargon term. Why do we call it atopic rather than allergy? So we call something allergic if you do the blood test, which is called RUST, and you find out if the specific immunoglobulin in IgE reacts to certain foods, drugs, chemicals, etc. But patients get confused because we use the word atopy, we use the word allergy. We say atopic dermatitis, we say eczema, we say food allergy, but we also say food intolerance. So let me at least say that in certain number of patients, removing certain food substances, whether you were truly allergic by skin test or RUST or not, could make a big difference. There are a number of patients that are intolerant to gluten, and they remove gluten, and they do fairly well. They might be intolerant to things in milk, and I say things in milk because it might not be the typical lactose intolerance. There's something else in milk called casein, and individuals respond to casein. We recently found out that there are certain molecules in meat, whether it's pork or beef, that individuals respond to. So if you can at least identify certain food substances to which you might not be truly allergic, like some people are allergic to shrimp, and they'll get into an anaphylactic shock. We're not talking about those. Then removing those within reason makes a big difference. And finally, there are a number of food substances that contain molecules that clearly many of you respond to. For instance, there are a number of food substances that have a lot of histamine. And obviously histamine is one of the molecules that we don't want to have high in your body. There's certain other food substances that contain salicylate. And salicylate is like aspirin. Aspirin is acetyl salicylate, and they might respond to those. There are many patients that respond to preservatives that we have in many foods, including most canned foods. So it doesn't have to be spicy food. And of course, spicy foods can do a job on you. And I want to stress that even though natural molecules might be helpful, and the luteolin belongs to a class of molecules called flavonoids, there are about 3,000 flavonoids in nature, and not all of them are useful. So for someone to go and buy soy flavonoid or isoflavonoids or citrus flavonoids doesn't necessarily mean that they're doing something good. For instance, isoflavonoids or soy flavonoids also have a lot of what we call estrogenic activity. They mimic estradiol, the sex hormone. So if, God forbid, you were to have had, or you worry because of your family history, you might have breast cancer or ovarian cancer, you should not get those because they will actually increase the chances of having. So again, we really need time with patients to describe what they may take and what other symptoms that might be there that might be counterproductive.
Also because I've had problems actually when I've been in the hospital, and it was my own feeling that I reacted heavily to some of the medications they gave me. And they also said that the steroids, I never saw anybody react to that before. That can't be true.
You can't be sensitive to antihistamines.
That can't be true. And if you come here to a hospital and you're intolerant to medicine, then we can't help you. And I've actually been really handicapped by that, because it's like, what do you do then? How do you get help?
And sometimes there's drugs that don't have preservatives you can get without preservatives.
Correct. Now, if, let's say, there is a medication that will take care of most of your symptoms, or a good portion of the symptoms, then there are places, and at the Brigham and Women's Hospital, there is such a center where they can try to desensitize you by giving you very small amounts over a period of time. Sometimes they do it faster as well, and you might be able to tolerate that. And I'm saying that because many patients, including Julia, doesn't tolerate many antibiotics. Yet many patients, like Julia, get a lot of sinus infections. So you need at least an antibiotic. And unless you go to someone with something written that says that's the only antibiotic I can take, they'll probably say no. They'll do what we call a bacteriogram. They'll tell you, oh, you can take X, Y, and Z, and you might not be able to tolerate it. So let me just say a word about stress. Obviously, for the longest time, we thought, oh, stress is only your mind. But stress is a physiologic reaction where the body responds in a way of trying to save itself to either real or perceived danger. Now, how does it happen? Somehow signals reach a part of the brain called the hypothalamus. They might reach through the eyes, through our skin, through smells, and we don't know which one, if not all of them, is as important as the others. Then the hypothalamus will activate another part of our brain, which is sort of behind our nose, called the pituitary. It's called the master hormone gland. And that will release about 7 different hormones. Some of them are hormones related to your menstrual cycle. Some are hormones that regulate, for instance, our blood pressure. And some go to 2 glands on top of our kidneys called adrenal glands, and they release adrenaline or epinephrine. And that puts us into a fight or flight mode. Now, obviously, our body developed that for good reason. We want to survive. The point is, it can get out of hand, or it can become totally exhausted. In both cases, there are problems. If it's totally exhausted, then you're absolutely crawling. And we can test that by measuring cortisol, which is one of the molecules that comes also from the adrenals. So the adrenals make cortisol as well as adrenaline or epinephrine. And it's important to measure also our thyroid because it's affected by that gland. Because if the thyroid is low, you will also feel very sluggish and sleepy and out of energy. And the energy is produced by organelles inside our cells called mitochondria, and they utilize certain substrates to make energy. So they burn pyruvate and they make lactate. And there's no question that the mast cells, just like they have the receptors c-KIT for their growth factor, they also have receptors for this stress hormone. And therefore, under stress, physiological or psychological, the hormone called corticotropin-releasing hormone, which in the United States is abbreviated CRH, in Europe CRF, for corticotropin-releasing factor, it stimulates the mast cells, and the mast cells release inflammatory molecules without releasing histamine, which means on a biopsy we'll never see the degranulation and we will be missing it. That's why whenever we get biopsies now, we do molecular biology to see if the genes that eventually will make a product are high, which indicates to us that the mast cells have been activated, even though we cannot see them under the microscope. And although we've said that it is important to reduce stress, it was uniquely interesting what happened a few months ago when Julia came actually at the Brigham for follow-up tests, and she was kind enough to give permission for us to look at your bone marrow biopsies on the microscope, and she was there looking at them with us. And she basically said, looking at her own mast cells in the bone marrow, that these cells they look strange. And we hardly ever look at the cells of the bone marrow because we stain them, and if they're stained and we can identify them as a cluster and a little spindle shape, that's it, you've got mastocytosis. So I looked at them with her, and in fact they looked degranulated. And I said, I've never seen degranulated mast cells in the bone marrow. And in fact, I conferred with my colleagues at the Brigham who had seen Julia, and they had never seen that either. So we said, well, let's see what might be activating these cells, because the mast cells leave the bone marrow and they're going to the tissues. And in fact, they're different at different tissues. And that's where they're hit by the smells, by the allergens, etc. We don't know of anything that activates them in the bone marrow. And since Julia had been saying to me, as you have already said too, that stress is a major factor, we said, what if we ever identify, if we can, the receptors for the stress hormone in your bone marrow mast cells? And as it turns out, they lit up like a light bulb. So they had all the receptors. So they said, well, if they have the receptors, they must be activated by CRH. So let's measure CRH. But where do you measure CRH? You can either measure it in the cerebrospinal fluid, but that's only coming from the brain. You cannot measure it in the bone marrow. So you can only measure it in the blood. And we said, well, maybe we're lucky it'll be behind the blood. And we had already published that it is slightly elevated in patients who have eczema. So I had the values. So then we measured her CRH in the blood, and it was 20 times higher than the highest I had seen. So immediately we said we should publish this because no one will ever believe that stress, emotional, physiological stress, can actually activate the mast cells, especially in the bone marrow, and show how it happens. And we wrote it together. She's also a co-author, and Dr. Kem Aikin from the Brigham is a co-author, and it will be published in the Journal of Pathology Clinical Immunology soon. I'm saying this not to butter my cup. I'm saying this because it was actually questions from you, questions from Julia, that led us to think of something we never thought about. And it continues to be very important to have rapport with you because this is a disease we don't understand. And unless we come up with answers to the things you ask, we will never really understand it. And the drugs that we use now for the aggressive type of mastocytosis are drugs that have to be given intravenously. Sometimes they work if you don't have the mutation. Sometimes they don't work if you have the mutation. But they're drugs that we call sort of high-end drugs. You really have to have a lot of problems. So for instance, in Julia's case, because your symptoms are fairly well, she knows how well, but fairly well controlled, one would not think of those drugs. On the other hand, as I said earlier, most of the patients do not suffer from too many mast cells as she does, but they suffer from the mast cells being activated as both she and you. And therefore, it is much more important in my mind to block the activation of the mast cells. And if you can have something that blocks the proliferation of the cells, so be it. And it turns out that now we might be very close to that because we have a cousin, if you wish, of the luteolin that I mentioned earlier, which is different in a way that I never expected would have better profile, but it turns out it does. So it blocks the mast cells even better than luteolin. It is absorbed actually better from the gut. We know its target, so we can actually follow up. And I always wanted to create a skin lotion for people that have very dry, like yourself, sensitive skin like hers, as well as those who have cutaneous mastocytosis. But these flavonoids like luteolin are yellow, and therefore I could not have used it in a skin lotion. It turns out that this methyl luteolin does not have color, and in fact we're very close to having possibly the last version of the skin lotion, which I hope might be available by the fall. It's already been tested on a number of patients with sensitive skin, at least doesn't bother them. Hopefully we'll have a benefit as well. And I will be talking about this actually at the Congress tomorrow. So we will hopefully have both a capsule with methyl luteolin as well as a skin lotion with methyl luteolin ready by the fall.